So the next call that presentation will be by Alex Mugge from the ONC, and she will be presenting on the new rules. So Alex is the Deputy Chief Health Informatics Officer of CMS.
Thank you. Thanks for having me. I appreciate everyone being available in this virtual forum and being so flexible. I know that we had all planned to be in Orlando, or many of us had planned to be in Orlando this week, but here we are doing a virtual conference in potentially much cooler climates. But I think it's great that we're all able to be so flexible and that we have this technology that's able to bring us together so that we can make this happen. So thanks again for having us on and for being flexible with us. And I'm going to go through a few slides here. I know that there's been lots of chatter about the CMS and ONC interoperability and 21st Century Cures Act rules that were finalized this week. And I will get to those in a second. I'd love to walk through those. But I also want to just make sure that we set a little bit of the context here and share some of the background and the reasons that we set off on this path. I also want to mention that I'm going to focus on the CMS interoperability rule. There is also, the ONC rule, which I think you're going to hear a little bit more about from Don Rucker later this afternoon. So I'll leave that to him and just talk a little bit more about the CMS side. So historically, there's been a significant lack of data exchange in healthcare that has led to a fractured healthcare system in which we've really seen that data is siloed in individual systems, and the players within the healthcare space are all forced to work with a limited or incomplete set of data. So for example, for patients rarely have control of their own healthcare data, and they often have to rely on their personal experiences or anecdotal information and what limited knowledge they have of their situation to make critical decisions about their health care. And frankly, that's just not a fair situation to put a patient in. And then on top of that, you have providers who are forced to treat patients with sometimes incomplete patient histories, sometimes incomplete information and drug lists or incomplete treatment histories, which really limits the care that a provider can give to a patient. And then you have on the payer side, payers are left with no option other than to pay patient claims and work off of the limited set of information that they may have as opposed to focusing on value-based care. So this has really been the history of our healthcare information exchange network. And with technology, we are seeing that there is much opportunity, and technology can really change this status quo. So going to the next slide. This slide really, so the previous slides really demonstrated some of that fractured healthcare system, and this slide is intended to demonstrate where we're trying to get to, this more connected healthcare system. So the federal government in the last about 10 years or so has spent about over $36 billion, as billion with a B, on health IT adoption, with the goal of getting all of this healthcare information digitized and more in one place. And for the most part, this worked. We now see that 78% of doctors and 96% of hospitals are using a certified health IT system. It's a huge improvement over where we were. And we're also seeing new innovators entering the healthcare marketplace at a steady pace. So those are all good signs. However, we are still seeing some of the same data silos in the sense that while the data is no longer on paper, it's in a digitized format in an EHR, it's still not flowing through the healthcare system the way that we might have wished. But along with this technology, we are seeing data that we've never had access to before. So instead of the patient's data being in a paper silo, we now see the data in electronic silos. So we're getting closer to where we need to be, but we still have a significant long way to go. But what does this mean for patients, having all of their data more electronically available? And it really means that the way that patients are interacting with the healthcare industry is changing. So patients are no longer passive participants in their care, but they can now have the ability to be empowered consumers of the healthcare industry. They have access to data that puts them in the driver's seat of their own care, allows them to ask questions and get information that they haven't had before. For providers who have historically worked with really an incomplete set of data, they can now unlock a huge amount of data about their patients, which will help them provide more informed and more value-based care, which will lead to better outcomes ultimately for their patients. And payers are in a unique position in healthcare. They're uniquely positioned because they have a one-on-one relationship with the patient, who is their enrollee, and with the doctors who they contract with in-network. So payers have a unique set of data that really allows them to engage more in this data sharing space. And that's really a part of where we have focused, CMS has focused its efforts most recently, and I'll get into more of that in just a minute. But again, I wanted to say our overall goal for the CMS rule in particular, is to get to a more connected healthcare system in which patients, providers, payers, and really all the players in healthcare have the right data they need at the right time to make the best informed decisions about the patient care. So looking at our roadmap slide, this next slide is intended to demonstrate sort of the CMS roadmap to interoperability, at least where we are now. I know there are lots of roadmaps to interoperability out there. If you go and search for some, you'll see ONC has one, lots of private industry has some. Actually, ONC has, I think, more than one. We've got some. But hopefully we're all aligning in the sense that we really want to make sure that we're putting the patient at the center of their care by exchanging data in the healthcare industry the way that we've been working towards for at least the last 10 years. Our particular roadmap to interoperability and what you see on this screen has a focus on patient access, on connecting healthcare through data exchange, and on innovative technology and standards. And then all of this is underpinned by a foundation of privacy and security. So if you look at the bottom of the arrow path that we have on the screen, you'll see that we have data exchange built on privacy and security because that is critical to the success of our mission and to the success and the safety of patients overall. When a lot of us think about data exchange in healthcare, or we think about just the concept of interoperability, many of us have an image of one provider sharing data with another. So one physician office sending data to another physician office, or one hospital sending data to another hospital. And our goal, particularly with our recent rules and some of the recent efforts that CMS has put forward, is to really expand that vision and ensure that interoperability is about all stakeholders in healthcare. And that's really why we've taken steps to engage payers and innovators more in the interoperability space lately. And I'll get more into those efforts in a moment. But when you think about it, there is such rich data that is beyond just the doctor's office. In healthcare, that if we can get all the data flowing to the right place in the right time in a secure fashion, we can really get to that interoperability that allows patients to accumulate their complete health record, which is really the end goal that we're trying to get to. So hopefully we can all agree, again, that if we put patients at the center, that we can really accomplish the goals that we've set out to accomplish years ago. So what have we done so far? What has CMS in particular done so far to support this interoperability mission? As I just mentioned, when we think about interoperability, a lot of us think about the data exchange between providers. Historically, the Meaningful Use program was focused primarily on providers adopting and implementing technology in their practices. The first stages of Meaningful Use were really focused on just getting that software into the office, getting the tech into the office, upgrading it, and digitizing the patient records, but again, kind of locally established in that one office. In 2018, CMS announced that we were doing a complete overhaul of this program, and we were really going to shift the mindset from the adoption of technology to more towards the sharing of that data that's been locked in that technology. How do we share that data throughout the healthcare system? And we renamed the programs the Promoting Interoperability programs to really reflect more of this new focus. Our focus on the use of APIs and that technology, and the use and the ability to exchange data and give patients access to their information. We really made that change with the goal of ensuring that data starts flowing, not just within one provider's office, but from provider to provider, from provider to patient, and more so our focus recently has gone into the data sharing even between providers and payers. In 2018, we also, along with the White House Office of American Innovation, CMS jointly announced the My Healthy Data initiative. And My Healthy Data is all about empowering patients and giving them access and use of their healthcare data. So at the same time that we launched this initiative, we also announced the Blue Button 2.0 API, which is the first developer-friendly application programming interface, or API, for Medicare beneficiaries. Blue Button 2.0 allows Medicare beneficiaries to access their claims data and send it to third-party applications and services right on their smartphones. So these applications are really intended to help manage and engage beneficiaries in their healthcare, as well as share their information with doctors and caregivers. So just to try to take a couple of quick real-life examples of this technology and how the Blue Button Patient Access API can have a real-life impact, I just want to share a few examples of some of the apps that we have already seen in this space. So we've already seen applications that have been developed to help Medicare beneficiaries manage their everyday health. So some of the apps will take claims data and sort of translate it into what is your treatment history, what are your drug lists, your provider lists, et cetera. So really managing everyday health. We've also seen apps that are established that have been created to help with onboarding, where a patient can send their data to a new doctor, so that doctor has access to their information at the beginning of their care or their treatment plan. So if you can imagine, any Medicare beneficiary who's on fee-for-service Medicare right now can pull out their smartphone and have access to their complete set of data. That's pretty incredible to be able to have access to that. And you know, certainly it has a very practical purpose of helping patients in their everyday doctor's visits. But here's one more example that we've been talking about recently that I want to share with you, that this may be a more extreme example of the ways in which this can really help patients manage their care. So if we were all in person, I'd ask to see a show of hands here, but I'll just assume that many of you are going to say yes when I ask how many of us have heard about the cruise ship that's quarantined or has been quarantined off the coast of California. So we're talking about a ship full of people, all of whom set off for a time-limited vacation and are now quarantined on a boat, or now quarantined in the state of California. When those folks set out for their vacation and they packed their medications, you know, many of them are seniors, many of them are on medications, and when they set out for this trip, they were planning for maybe a 7-night cruise. They may have taken one of those pill boxes and put all their medications into pill boxes with just the 7 days that they needed, the 7-day supply they needed for this trip, not realizing that this was going to turn into potentially a 14-day quarantine. So many of the patients many of the people that are on this cruise ship may not have the supplies they need to last that full 14-day quarantine, and they may not have access to their prescription bottles to know what pills they're taking either. Imagine if they could pull out their smartphone and access a Blue Button-like application or patient access API that would list out those drug lists, and they could share them with the medical professionals on board to say, these are the drugs that I need to maintain my health. That's not something that everyone has access to right now. That's not something that particularly all seniors who may have multiple medications they're managing all at once, they may not have that drug list readily available. But through apps like patient access APIs, they would be able to pull that out on their smartphone with little effort and ensure that they can get the right care that they need. And sure, this is an extreme example, but we are all in uncharted times here, and this is a real example, and it shows how technology can really benefit patients and their caregivers alike. So really critical real-life uses of this technology. And shows just that having access to data at the touch of a button can really transform the way that patients are interacting with the healthcare industry and the way that they can take control of their own health. So I guess, so moving beyond just the patient access API, which I've already established is a critical part of patient empowerment and engagement in their care. But interoperability isn't just about providers sending data to providers or patients having access to their own information. Again, interoperability is really the flow of data with all players in the healthcare space. With that in mind, last summer, CMS launched our Data at the Point of Care pilot. And Data at the Point of Care is an API where CMS can share Medicare claims data directly with providers. So providers have that data readily available in their EHRs before a patient even walks into their office. This type of data can significantly improve care coordination and efficiency during a doctor's office. So imagine if a doctor signs up for the Data at the Point of Care pilot and is able to access, they know they have an appointment coming up with a patient and they're able to access that patient's claims history, which gives them a glimpse into their treatment history. Imagine this world now where the patient can walk into the doctor's appointment with a brand new doctor and not have to fill out that dreaded clipboard, not have to consult their prior medical records and fill out pages and pages of paperwork. But having that health history already there and available to the provider so that when you walk into your appointment, you can get right down to the business of why you made the appointment in the first place. That's a very real application of our Data at the Point of Care API and something that we look forward to expanding more to other providers as this takes off. We truly believe that these APIs will help to lead to better care, that it's focused on the patient and not so much on the process. So oops, I'm not sure what I did there. All right, sorry, going back here. So getting to what we've all been, or many of us have been talking about this week, the CMS Interoperability and Patient Access Final Rule. So this is our most recent accomplishment. On Monday, actually, we finalized this rule. As I mentioned before, ONC has also finalized their 21st Century Cures Act final rule, which they will cover later this afternoon. So I'm going to focus just on the policies that CMS finalized in the Interoperability and Patient Access final rule. And the timeline that you see on your screen really walks through each of the proposals. I'm going to go through them in order, starting with what's going to happen in the fall of 2020. So 6 months from now, hospitals, as part of their conditions of participation in Medicare and Medicaid, will start sending event notifications upon patient admission, discharge, or transfer. So whenever a patient has a status change of an admission, discharge, or transfer, hospitals will send a notification to their primary care doc or doc that's been associated to them to alert that doctor that, hey, this patient's had a change in their healthcare status and it may be something that you need to follow up on. This we believe will truly improve patient care coordination and ensure that if a patient is discharged or transferred with a particular condition that may require follow-up, that they don't fall through the cracks, and that this allows their provider to follow up directly with that patient and ensure that they are not lost in the healthcare system, but there's some care coordination and follow-up there. Later this year, we will begin publicly reporting the names of clinicians and hospitals who have attested to certain information blocking provisions in a manner that indicates they may be information blocking. So as part of our Promoting Interoperability programs, we do have certain attestations that clinicians and hospitals are required to complete that talk about whether or not they have engaged in information blocking. And if they indicate that they may have been information blocking, we will publicly report that on our websites. We believe that this will allow patients and other providers to really assess the right care that they need and whether their provider is going to help facilitate the exchange of information, or whether they may be information blocking and withholding that information that could help better their care. At the same time, or a similar time frame later this year, we will also begin publicly reporting the names of providers who have not entered their digital contact information in our NPES provider directory. This is a really good starting point. This proposal is really intended to start incorporating more interoperability data, so digital endpoints, into provider directories. Provider directories can be incredible tools for connecting providers to one another, connecting providers and payers, and helping patients get the care that they need, but only if that information is, one, up to date and accurate, but two, includes things like digital contact information that will help facilitate electronic exchange. So this is a first step that we're taking towards improving data and making it more complete data. We know that there's a lot of work to do in the provider directory space, and there's a lot of improvements to be made there. And so we hope to work on that more in the coming year. So I'll leave that there as a teaser, but more to come from CMS on provider directories, certainly. Then getting to the next proposal on this timeline, starting in January 1, 2021, this is really where the rubber hits the road for patient access. This is where CMS has finalized that all payers, all federally regulated payers, so Medicare Advantage, Medicaid Managed Care, Medicaid Fee-for-Service, CHIP Managed Care, CHIP Fee-for-Service, and the qualified health plans in the federally facilitated exchanges, all of those payers are required by January 1st, 2021 to implement a patient access API that is similar to what I was talking about with our Blue Button API that CMS has for Medicare fee-for-service folks. We are now expanding that policy and requiring that all of our federally regulated payers implement a similar patient access API that will allow their enrollees to access claims and encounters and certain clinical information as well directly from their smartphones. This has been one of the more major proposals that we've heard about over the last year since the proposed rule was out. We did finalize it pretty much as proposed with a lot of support and a lot of enthusiasm from the patient community. One thing I want to highlight that we've added here in the final rule is that we did add a privacy attestation in response to the comments that we received on this proposal. What we have included is that we are now allowing the payers who build these APIs, we will allow them to require that the apps who are requesting access to those APIs attest to certain privacy conditions. So attesting that they have a privacy policy that is in plain language, that their patients have seen and affirmatively acknowledge that they have seen. We're allowing the payers to really do that to ensure that that we're all working together to educate patients on the privacy aspects of these applications. So in addition to that, we're going to be putting out very shortly some patient education resources that payers can use to work with patients to ensure that they're selecting the right apps for them. But this all comes back to, like I said, that foundation of privacy and security that is so critical for the success of our mission. And we are very proud to say that we were able to build that into the final policy to ensure that we're working collaboratively with payers to ensure that patients are getting the right information that they need in the most safe and secure manner possible. So spend a bit of time on that one. I want to say that also on January 1, 2021 is when the payers will be required to make their provider directories available through a FHIR-based API. So we know that there's, like I said, a lot more work to do in the space of the accuracy of provider directories and provider directory data overall, but we believe that this is a good first step to making this data more available to patients and to innovators. Then moving to the next policy, starting on January 1, 2022, patients will be able to take their data with them when they move from one payer to another as they navigate the healthcare system. This is critically important because just because you're changing payers does not mean that you should lose access to your data. We're working hard to ensure that patients have access to that data and are empowered with that data. We don't want to see them lose it just because they're going to a new health plan. So now when patients, or starting in January 1, 2022, when a patient changes payers, that means they will be able to bring the data with them to the next payer and really start to establish that cumulative health record that follows them with them throughout their life. It's important to note on this one, particularly for this audience, we did not specify a mode of transmission for this data, the data that gets transmitted in this policy. Unlike the API policies, we did not require that this be done through an API. However, we do anticipate that most payers would choose an API platform to do this data exchange, and we will consider future rulemaking in this space, just given some of the comments and the feedback that we have received on this policy. So perhaps more to come on that one, but certainly for now, we're very excited to know that patients will not lose their data and they'll be able to take it with them when they change payers starting in 2022. And then finally, the last proposal in the rule is that in April 2022, we will be requiring states to exchange certain data on dually eligible Medicaid, Medicare beneficiaries with CMS daily. And we required this data exchange on a daily basis to ensure that we have better benefits coordination and that we're really looking out for this this population of dually eligible individuals to ensure that their care is coordinated, their benefits are coordinated. So we'll be working with the states to make sure that data exchange is happening on a daily basis going forward. So going to the next, oh goodness, sorry about that. Going to the next slide, this just highlights some of the impacts of the rule on the patient in particular. The impacts of this rule are wide-reaching, but I want to highlight that we don't look at this as being an endpoint. Interoperability is never an endpoint. It's a journey, and a journey that we're all on together, and it's a journey in which we hope that we engage the patients, providers, payers, and innovators, developers, all stakeholders in the healthcare space to ensure that we're working together to get towards that goal of interoperability. Together with the ONC rule, these rules both address technical factors and industry factors that have historically created barriers to interoperability. So we're proud to say that together these rules work together to ensure that we are moving away from information blocking and data silos and moving more towards the free exchange of data in a secure manner to better patient care. One thing I want to highlight, and you'll hear certainly more about later this afternoon, is that CMS and ONC have both identified the HL7 FHIR Release 4 as our API standard for interoperability, really aligning all of industry in a common direction on the FHIR 4 APIs. So looking forward to seeing those implemented in the coming months and years. So something for all of us to watch out for. And I just want to close by encouraging everyone to think about the ways in which your organization may contribute to this atmosphere of data exchange and the technology platforms that are necessary to support this data exchange going forward. Think about the ways that you can contribute to this, and think about the ways in which we can work together to really ensure that everyone in healthcare has the right data that they need at the right time, because that equals the right care for patients. So something for all of us to consider as we move forward with the implementation of these rules. We sort of look at this as the end of one policy stage and the kicking off of an implementation and development stage that will be critical to the success of these policies. So something to think about as we go forward and as you listen to the rest of the presentations today. I do have just this last slide up here with our website where we had posted the final rule. On this website, there's also significant resources available, implementation guidance, lots of documentation to help payers with the development and implementation of the policies. Highly recommend that folks check out the resources on this page because they will really have a significant impact on implementation. So please take a look and do let us know if you have questions. We're always open to hearing feedback, particularly on what other resources we might be able to make available. And with that, I'm going to open it up to questions.
Yeah, Alex, so we thank you for the presentation. We do have some questions. So, these rules are slated to basically be required by January 1st, 2021, and will impact payers through their patient access APIs. And there's nearly 1,000 organizations that would have to do this. Are there any penalties, or what are the incentives for them to do this if they just simply ignore the rules?
Well, that is a great question. So the requirements of this rule become sort of part of the payer's contract with the federal government. So if you are participating in Medicare Advantage or Medicaid Managed Care or the QHPs, it varies by program, but it does fall under the contract that you have made with the federal government to participate in those programs. So, for example, with the QHPs, this is part of your certification requirements in order to participate. So the impacts, should someone not be compliant with the policies, vary by program and by circumstance, but certainly this is a requirement just like any other requirement of being part of these programs. And we do anticipate full compliance from each of the payers.
Okay, great. Another question from Jude is, how do you see this impacting non-CMS regulated payers? Like, do you see that employer health plans have to follow a similar suit for patient-mediated APIs?
Yeah, so and that one's really interesting. So a couple of things there. While this is not a requirement for of course, the non-regulated payers, we can't regulate the non-regulated ones, but we have heard from many of those folks that there is an interest in doing this. Also, there's a significant overlap in terms of like the parent organizations of folks offering one of the plans that is regulated and also offering an employer type plan or a non-regulated plan. And I think that the mindset that we've heard so far is, if I'm going to make this available to the patients in my regulated plans, why wouldn't I also make this available to the folks in the non-regulated plans? I mean, this is certainly a patient benefit and one that can help the relationship between payer and patient and can be a great marketing point even. So I think that what we've been hearing pretty much across the board is that it will be made available to both types of plans where there is overlap. I'm sure there may be some exceptions to that. We are definitely working with the employer-sponsored plans and encouraging folks to really think of adopting this, as this will become the norm in the future.
Got it. No, it's very helpful. And another question from Anirban. Can you clarify the difference between claims and encounter data and the US CDI data that is required?
Sure. So for claims and encounter data, we're talking about the data that if you were to look at your health plan's explanation of benefits today, that's sort of the information that you would see, like you had a claim on X date with X provider, and the cost was X dollars. So that's sort of your claims and encounter data. Of course, we also include prescription drug claims where applicable. So that's sort of the nitty-gritty on the claims and encounter. Of course, that data also certainly provides a lot of insight in terms of your treatment history, provider lists and drug lists and so forth. The US CDI data is more the clinical side of data, and if folks take a look, if you Google US CDI, ONC's website has a lot of fantastic resources on the US CDI, including a list of data elements that are included there, and that's more some of the clinical data, lab results, other more clinical items that a lot of payers actually have more access to than you might realize, and that a lot of payers do maintain some of that information. So that's really getting at some of the clinical side of the information.
Got it. Okay. And we have a question from Deepak Sadagopan, who will be one of the panelists actually later today. So first of all, he's grateful. I'm grateful that the rules address exchange of clinical data, improves scalability through better standards, and removes blockers. However, I'm concerned that the roadmap does not include administrative needs for digitizing payer and provider data exchange to support transitions of value-based care. Without that focus, the scalability of industry initiatives to value-based care will be challenged. Most of this data exchange happens by Excel today, emails and PDFs, which are not scalable. What are your thoughts on those payer to provider data exchange?
So I think that certainly with the policies that we have put in place today, we are focusing on the data that is available, readily standardized, available for data exchange. There is significantly more data in healthcare, and ultimately we would love to see the data that is exchanged expanded to the complete patient record set. And that is something that we are working towards. And I would also include in that the administrative type data that you were referencing. And that is something that we need to work towards. Like I said, interoperability is a journey. It's never going to be an endpoint. It's a goal that we are all working towards. And because technology and data in healthcare changes frequently, it's something that we'll have to stay on top of and continue to update our rules and policies and technology to keep pace. But this is absolutely a field or an area which we know needs additional work, and we haven't lost sight of that. We do hope to add more and more data to this data exchange over time.
Awesome. So another question from James. Do you foresee a migration from the current HIPAA X12 claims processing to a FHIR API-based claims processing environment? That
is another great question. It is something that I think we would love to hear more from industry about. Of course, the X12 standards, the HIPAA transaction standards, those that have been declared through rulemaking are set through rulemaking at this time. It would take additional rulemaking in order to change those. But before we get to rulemaking, we really need to hear from industry what is the desired move there. Is it to move towards FHIR? Is it something else to stay with X12? It's a space that we are actively engaged in and exploring, but we do need industry feedback, and we work closely with NCVHS and through the ONC High Tech. For example, right now they're looking at the prior authorization standards, the X12-278, to see whether the prior authorization, whether there should be any innovation in the prior authorization standard space. You're asking about claims. I think that these are all things that we are curious to learn more about. But there is a process for getting there, and we need to hear more from industry and work with folks to make sure that whichever direction we choose is really in line with industry's goals.
Yep, that makes a lot of sense. And, you know, a lot of us had anticipated the ONC's direction as it was built on the Cures Act. I'm wondering what motivated the CMS rules as health plans. You know, they kind of stood as observers or influencers during the meaningful use debate rather than direct participants in the interoperability.
Yeah, and you hit it right there. I think we've definitely focused a lot of our interoperability efforts historically on providers, you know, clinicians and hospitals through the Meaningful Use program. But we know that payers have a lot of really rich data on patients, and they are uniquely positioned. Again, you know, they have this relationship directly with the patient as their enrollee and directly with the provider through their contracted networks. So they're in a really unique position to support interoperability. Specifically, this rule, you know, while you're right, it is not statutorily mandated. Unlike with the Cures Act rule and ONC's rule that came out of legislation through Congress, this rule was a bit more homegrown. And it really came from that space of wanting to expand interoperability and also some sort of more personal experiences and anecdotal stories that we have here. So I'm not sure if many of you have heard the story from our administrator, but very quickly, she was on a trip with her family, and she was headed back to DC while her family was headed back home to Indiana. And she got a phone call from her daughter saying that her husband had passed out in the airport. He had a medical event that was extremely dangerous, and not very many folks survived what he went through. But, in part, it was her. So she, of course, was, on her way to D.C., and so she's trying to get back to Philadelphia to deal with her family situation. And meanwhile, she's calling all of his doctors and all of their friends and trying to get his medical history scraped together. And she really didn't have access to the information she needed to give to the paramedics to ensure that they could provide him the best possible care. That's a terrifying situation for anyone to be in. And she, as the administrator of CMS, did not have the right data that she needed. And so she really identified an opportunity there, knowing that she needed to make sure that other patients didn't end up in that situation. Long story short, he survived, and he is now doing well. But when they were discharged from the hospital, she also asked for his medical record from the hospital, and they were not able to readily produce something for her that was usable on the spot. They did ultimately give her a CD-ROM and a few sheets of paper, but it wasn't, the data wasn't in a readily usable, easy to access format that would have made it easy for her husband's doctors to form a treatment plan going forward. And so that, in a lot of ways, I think is the underpinning for our mission and why we've taken on interoperability is, she saw that from her position as the administrator of the largest payer in the world, she was not able to get enough information to try to help her husband in a time of need. She didn't want any other patients to go through what she was going through. And so we have, I think that's certainly part of the motivation here, but also just across the board, all of us having had experiences like this and knowing that we're in a position with all of this rich payer data where we can really help patients, that we thought that this was a critical mission, a critical thing to engage on. And that sparked a lot going forward.
Hey, Alexandra, we've got some distinguished people from the Da Vinci group that are joined you here. And if you had a few more minutes, we can give them time at the end before dawn. But they wanted to say hi, and they had some questions of their own. But if you could hold on a second, at least say hi to you. Jocelyn, you want to talk? You there?
The dreaded double mute. Hey, Alex, it's Jocelyn. Thanks so much for that presentation. I'd like to first thank Alex. She actually popped on a call for our Da Vinci community yesterday and gave an abbreviated version of this presentation. The work coming out of CMS has been really important to us. For folks that aren't aware of it, and I think Alex did a good job of not answering directly on behalf of commercial payers, but what we're queuing up for the next hour is really a conversation with Da Vinci participants. Alex actually sits on our steering committee, and we'll hear from a number of other steering committee members. But CMS, under the leadership of her predecessor, Melanie Combs-Dyer, actually have funded significant portions of the work that we're getting done because we know how important this is for CMS and the commercial payers to be working in standards in a collaborative way versus sort of at home in their own backyard. So I appreciate that. I am curious though, Alex, I've seen you do the presentation a couple times. When we look at the timelines, and I think you touched on this a little bit, I think there's some places where we do have work in progress standards and there's an existing V2 standard to do work. I'll talk specifically about things like ADT. Do we call out, and I've been a little busy this week, so I haven't dug into the details and the meat of the rule. do we call out, I've fielded a couple questions, whether someone's existing V2 ADT messages are going to suffice for that notification work that's expected to be done by the fall this year?
So we didn't specify a standard for the ADT messaging. What we did say was that that the policy only applied to those hospitals that have an existing EHR that could support this type of notification. I think, we've definitely heard some feedback and questions as to whether those notifications would move to FHIR. And it's something that, we'll continue to monitor and see what we hear from industry. But at this point in time, we really wanted to ensure that the hospitals who are implementing this policy actually already have the technology in place to support it. Again, there's only a 6-month turnaround for this policy. Right. So we're looking at this happening 6 months from now. We wanted to make sure that hospitals were set up for success and that we could start this type of care coordination notifications as soon as possible.
And Alex, I'd encourage you, we've got Sagrin Moodley on the phone. Hans is with us from Cerner, Chuck, Brian Patty, Deepak, as you heard earlier, and Kirk Anderson. If you want to stick around with us while we talk and do some Q&A, we'd love to have you, but I understand if you have to disappear.
Unfortunately, we do have another meeting starting right now, so I'm going to have to jump off, but would be happy to have a follow-up or additional discussion some other time. This is great, and I really appreciate all of the questions that folks have asked today, and hope that we can continue to provide some guidance in this space. But thanks very much for having us, and we'll be back on later today after our other meeting. So thanks again.
Thanks, Alex.
Thanks, Alex.